Hi, good morning. We are honored to be invited to present our project at the BSG Live. I will talk you through our project today. So we attempted to review the use of intravenous ustekinumab reinduction strategy to recapture response in patients with refractory Crohn's disease, whether this could be a plausible strategy in the long run. So we recognize that Crohn's disease can be such a clinical challenge because of its unpredictable and progressive course, and many patients relapse. A big Italian observational study on Crohn's patients found out that nearly half were free of clinical recurrence, with the other half experiencing significant relapse, of which 30% needed an added surgical treatment. And it has been well known that anti-TNF is considered the most effective treatment in many CD phenotypes, even to date. Having said that, according to the IM-UNITI trial, we saw that the annual rate of loss of response to infliximab reaches about 10 to 20% per year. We have come a long way since 1998, where infliximab was initially introduced. And in 2016, we were presented with ustekinumab, which is now considered as the by many people as the next line effective strategy, effective treatment to treat Crohn's disease. It is a human monoclonal antibody that acts as a cytokine inhibitor targeting the IL-12 and IL-23. It resulted in many cases in clinical response to up to 49% at 52 weeks, and endoscopic response rate of 63% after approximately 1 year in those with anti-TNF experienced cohort. Even so, about 15 to 35% of patients still develop loss of response in the first 3 years of treatment, according to the IM-UNITI trial in 2021. We were lucky to be presented with the sequence trial on risankizumab recently that shows how this new therapy can be non-inferior and in fact superior to ustekinumab in many aspects, and hence can be considered as a next line therapy in those with loss of response to ustekinumab. The only problem is that it is very expensive. But we saw that the Janssen patent on ustekinumab is expiring next month, and therefore we expect in the next few years there will be more and more cheaper biosimilar agents to ustekinumab, and hence extending the durations of use of this therapy can potentially save costs to the unit in the long run. So we have seen that there are various strategies to recapture response or to intensify dose delivery being trialed recently. Some of them reviewed the effect of escalating the dosing of ustekinumab to 6 weekly instead of 8 weekly. Some studied the effect of escalating the treatment to 4 weekly, and some reviewed the role of intravenous reinduction strategy in those with secondary loss of response to ustekinumab. At St. Mark's, we offer one unlicensed reloading dose of intravenous ustekinumab in place of subcutaneous dose to recapture response. And this has been the strategy that has been adopted by St. Mark's since 2019. So our aim is to review the effectiveness of this strategy in inducing and in maintaining remission over the long run in Crohn's disease patients with secondary loss of response to ustekinumab. We did a retrospective longitudinal study over 4 years period between 2019 to 2023. We included patients more than 18 years old with diagnosis of Crohn's disease. We used the Harvey-Bradshaw score to determine clinical response and clinical remissions according to the definition in the bracket. We also observed the biochemical response defined by reductions in the fecal calprotectin by more than 30% from baseline, and biochemical remissions as fecal calprotectin of less than 250 milligram per gram. We also looked at CRP and albumin as markers of biochemical response and remission. These are our primary outcomes, which you can see in the poster. And this is the secondary outcomes, where we looked into the role of BMI and peri-anal disease presence or absence in predicting the outcome of the treatment of this treatment strategy. So this is demographic data. You can see that in the poster. And we found that most of our patients has allocolonic disease, and most of our patients has a non-scripturing, non-penetrating disease according to the Montreal classifications. Also most of our patients has no peri-anal disease, with most of them uses ustekinumab as the third-line therapy along their treatment sequence following failure of anti-TNF. The primary outcome, basically, we have found out that about 70.91% who adopted this strategy experienced treatment persistent to date, with only 21.8% of patients experiencing treatment persistent of less than 12 months. And we also found out that most of our patients, even if they have to switch their therapy after a year of reinduction strategy, they still managed to gain an extra 20.48 months. We also saw that this strategy has led to major improvement in the HPI score and the fecal calprotectin score, but not for CRP and albumin. And using our physician global assessment for peri-anal disease, 53% experienced improvement. And our secondary outcome, looking at the role of BMI on the ustekinumab treatment, using the log-rank test, we found that there was no statistical difference in ustekinumab treatment pre-reinduction as well as post-reinductions. The same goes for peri-anal disease. We saw that there is no difference between peri-anal disease absence or presence on predicting the treatment outcome for ustekinumab. And the same pattern applies for the treatment outcome between these two groups following intravenous reinduction strategy. So our conclusions are that intravenous ustekinumab reinduction is a reliable strategy to recapture response in those with refractory Crohn's disease. And even in those who required a biologic switch after 12 months of reinduction, they still managed to gain an extra 20 months on ustekinumab. This can potentially save costs to the unit in the long run. Having said this, we don't have definitive data on the predictive factors of treatment failure. So we thought that a bigger data sample is needed. And for this, a multi-center studies and multi-center collaborations may be necessary. So some of the consideration for future studies to help to reach a more robust conclusions on our study is to look into or to compare between the treatment outcome of different strategies, such as comparing between the 4-weekly strategy, 6-weekly strategy versus intravenous reloading strategy. We might also want to do a cost-effectiveness analysis to review how the strategy can potentially save costs to the trust in the long run. And we may also review other potential factors that may predict the treatment failure or success of this adopting this strategy, such as the effect of central adiposity, and perhaps the sequence of ustekinumab on the patient's biologics list may have an effect. There could be difference in the outcome between the male and female versus female patients, and perhaps different disease phenotypes react differently to this intravenous ustekinumab reinduction strategy. With that, I thank you very much, and please enjoy our poster, and please do ask us any questions if you have any inquiries. Thank you.